Hello, I'm Dr. Scrascia. Thank you for the opportunity to share my presentation with you all. I'm an oral surgeon and periodontist. Today I'm gonna talk about management of the soft tissue around the implant. If we don't plan the treatment, we plan for failure. What's most important in our practice is the study of the treatment plan, because if we do not evaluate meticulously all the clinical parameters, we can already anticipate failure. For example, in this specific clinical case, we can easily notice that the distance between the implants and the number of the implants is not correct, and the soft tissues is lacking keratinized tissue. So it was predictable since the beginning that eventually the patient would have come to this situation, as we can observe in the picture as the bottom right side. Consequently, this is an induced periimplantitis. The periimplantitis are or periodontal periimplantitis or induced periimplantitis. The induced periimplantitis could be or surgical or prosthodontics. Surgical for the incorrect implant placement, for the incorrect management of the soft tissues and the hard tissues. In the prosthodontics, incorrect functional loading, incongruous prosthetic frameworks. As far as the periimplantitis, in this specific case, I will talk about and examine the complication that could occur to the soft tissues. The periimplantitis from periodontal disease. We have to remember that the etiopathogenesis of the periimplant disease is similar to the advanced chronic and aggressive periodontal disease. So this is an extremely important research. I use often this research because it's one of very few studies in which patients with generalized aggressive periodontitis were treated with implant and compared to periodontally healthy patients and patients with chronic periodontitis. And we can clearly see the graphic showing complications and bone loss over a 3 years time follow-up. It was more severe in the patient affected by generalized aggressive periodontitis compared to patients with chronic disease and healthy ones. So, this means that before thinking about any surgical implant approach on patients with periodontitis, we must make the correct diagnosis based on the type of periodontitis. What I can say, according to the Italian law, and probably most other countries, underestimating a patient with periodontal disease and lacking the right periodontal treatment leads to malpractice. Then, what we do know under a periodontal point of view, that chronic periodontal disease and aggressive localized periodontal disease, if treated correctly, will result into a positive prognosis. Why? The aggressive localized left undertreated will definitely result into an aggressive generalized case. And the aggressive generalized cases, even when treated, we know from the literature, still have an uncertain outcome. Then, when we had to treat with implant patient with periodontitis, which has to be executed with periodontal chart and eventually using microbiological samples that can be useful to determine bacterial type. and executing restorative therapy and eventual extractions, and periodontal treatment alongside patient compliance. Then, the execution of eventual surgical periodontal treatment. After all these, execute implant therapy. Because we have to keep in mind how most of the treated patients, 80%, will experience periimplant mucositis, and that between 28 to 56% of patients will have periimplantitis. What can be done in periimplantitis? Surely, the first approach would be to surgically decontaminate the implant surface to clear the infection, but there is no scientific evidence. There is no scientific evidence about the correct decontamination technique, nor about an eventual regenerative technique to be used to correct periimplantitis with intrabony defect. But we do know that periimplantitis is an irreversible disease because from morphometric studies we know that once the implant surface is contaminated, it will show carbon dioxide. And this means it is corroded and no reosseointegration can take place, but eventually only ossification that can cause an improvement of clinical parameters. For example, in this clinic case, the patient comes in for a follow-up 4 years after the surgery, after missing all recall system. So I decided with the patient to remove all crowns on the implants and executed a regenerative technique with BIOS and BioGuide and adding endogain. During surgical re-entry to reinsert the crowns, I was gladly observing the positive results that you can see on the left pictures. Although I know this is not a reosseointegrative process, but only a ossification process around the implant. So, to avoid generating periimplantitis, a correct surgical approach must be determined through a great knowledge of surgical technique and deep study of soft and hard tissues. And in this speech, I will examine particularly how to handle soft tissues. The implantologist needs to recreate the biological context to make sure of the stability over time. In other words, the surgical approach has to match the parameters of periodontal surgery. In this meta-analytic study, Zikdon and Maciej showed how to achieve stable soft tissues over time we need to have a lot of keratinized tissue. Consequently, avoiding tissues recession, this will allow us to have crest bone stability without bone resorption. Certainly, if we have a thin periimplantitis tissue, we will have a higher risk of resorption compared to the thick tissues. So, soft tissues integration definition is a biological process that happens during the building and maturation of the link between soft tissues connective and epithelium and transmucosa portion of the implant. And considering that the maintenance of healthy soft tissues barrier is an important as osseointegrative process itself. Then we have to keep in mind that periimplant tissues are similar only as far as the shape, but the connective tissue close to the implant is relatively acellular and not vascular raised. This area, which is more attacked by bacteria and mechanical force, it is also the area with less fibroblasts and circulation. So the literature confirms that periimplant tissue must be stable and fixed, with a sufficient quantity of keratinized tissue to avoid the recessions moving forward. How do we determine whether the tissue is a thick biotype during our clinic activity, at least 2 millimeter thick? Using a periodontal probe into the sulculus, Mueller suggests us the periodontal probe when we put a periodontal probe and is not visible, the tissue is considered thick. We have to consider risky cases, patients with a thin biotype, with a highly festooned, badly positioned teeth, triangular shaped teeth. This is very high-risk patients. So we have to consider as low-risk clinical cases, all the opposite cases, such as the thick biotype, lowly festooned gingival shape, and all over parameters. Therefore, we have to take in consideration all those parameters, knowing that if we have a thin biotype, we have to contrast the possible loss of soft tissue caused by implant therapy and prosthetic procedures. While in case of thick tissue, we have to execute invisible incisions like intraocular without traumatizing the papilla, because the thick biotype has inclination to non-aesthetic incision lines. So the decisional criteria to manage soft tissues are surgical procedures, incision technique, and connective tissues graft. For the surgical procedure incision technique, for patients with thin biotype in aesthetic areas, we have to plan the mucoperiosteal flaps for the following reason: preserve blood supply, give access to the local bone collection, give a surgical seam far from the implant sites and from the increasing areas. Periimplant tissue surgical management, the implant therapy requires surgical procedures that needs to be considered plastic and reconstructive. Barely visible incisions, allowing incisions without tension, preserving the circulation on the flap margins. So curved chamfered incisions and aberrate chamfered incisions. Needs to start under the tension of the alveolar mucosa to the interdental papilla, distal to the edentulous space contiguous teeth. Then it goes sinuously in the adherent gingiva, finish very crystally on the palatal side. Forty-year-old patient coming to me to the office for a fracture of the central left incisive. The patient had a thin biotype. Then I executed an incision under the tension of the alveolar mucosa to the internal papilla, and I regenerated the bone defect and increased the soft tissue using a connective tissue graft. Kept track of the healing process, and after having executed the implant therapy with flat glass technique, this is the result after 5 years. I care about showing you how the incision technique permitted to achieve a satisfactory aesthetic result. Next clinic case, 50-year-old patient at the clinic for the fracture of the same central left incisive. Still to notice the incision lines, we can see vertical and horizontal bone defects with descents of the buccal plate. Bone regeneration with not absorbable membrane was executed with bone chips extracted from the cheek branch pillar to increase the volume of the soft tissues. I pedicle a connective tissue. For the surgical re-entry to remove the non-reabsorbable membrane and insert the implants, we can notice in the right top pictures the bone regeneration achieved. Just as in the two pictures, we can notice before and after the amount of mucous tissue obtained without scar tissue. Another incision technique for the thin biotype, in the case of monodentulea, it's the brief incision. In this case, the bone fenestration has been handled with an only bone taken from the anterior nasal spine, which mixes with maxresorb and allowed regeneration of the pocket. But to avoid non-aesthetic outcome in thick biotypes caused by linear incision, intraocular technique would be recommended. This is a short video. So in this short video, this is a specific case. I had to execute an extraction of the second premolar on the top right side for an endodontic failure. We can see the intraocular incision technique having a correct finger position in relation to the blade, so I can enter parallel to the vertical tooth axis. The distance is to be determined having a correct holding point using the right oral. In this case, I use the Minnesota retractor. This is the technique. Other clinical cases for intraocular incision: 45-year-old patient with aggressive localized periodontitis was treated with periodontal therapy. Once the patient compliance was in place, we could proceed inserting the implant in area 3.1, alongside a regenerative technique with endogain for intraocular defect as the distal wall at 3.2. So we can observe through X-ray the bone amount obtained and the filling of the bone lac defect. Another intraocular incision case of thick biotype, compromised teeth caused by invasive cavity process that could not be handled with crowns lengthening surgical procedure because of short trunk root with a very high truncation. After executing an atraumatic extraction, allowing us to maintain the four alveolar walls intact, we have to be careful to preserve the papilla. For example, stitching it. After this, I proceed to insert the implants immediately after the extraction in an ideal position, filling the intrabony defect using heterologous bone and positioning 2 layers of reabsorbable membranes under epithelialization of the periimplant thick tissue. So this is the result after 5 years follow-up. You can see the level of the periimplantitis tissue. In the next clinical case, 40 years old woman, aggressive localized periodontitis, loss of 3.2. What we can see in this X-ray is the presence of a very thin alveolar bone process on contiguous elements. And this is the arthroprosthodontic steps. And this is the result, a follow-up after 13 years, where we can notice a good integration of the crown in relation to periimplant tissues, and a good comparing the X-rays. We can see bone regeneration, a very good bone regeneration, thanks to the thin alveolar bone process of the contiguous teeth. Then it's very important to evaluate the level of the bone. And this is the level of the bone at the end of the regeneration. Among the decisional criteria, we have to understand when to use connective tissue grafts. When we have to handle the soft tissue with connective additions, we have to ask ourselves for a correct plan in treatment to avoid failure: when, why, and how. When? Always thin biotype. Absence of residual keratinized tissue. Why? Half long-term recessions. How? Sampling techniques versus membranes. It's extremely important in implant therapy to apply surgical procedures coming from periodontal surgery to increasing soft tissue around the implant and teeth. The connective tissue grafts can be taken from different spots such as the palate, dentulous areas, mucoperiosteal flap, and tuber. In the withdrawal of connective tissue from palate, the most important factor for the donor site is the palate vault. A flat one has minor amount of connective tissue, and this can affect the increase of keratinoid tissue that we need to regenerate. Therefore, using this type of anatomic situation, using collagen matrix membranes, as we will explain later, can be a good solution. So, to get the donor site ready, we can make a linear incision or angular ones, or to withdrawal free gingival graft incision. For the angular incision, I can present a clinical case, and in this clinical case, showing connective tissue graft to treat multiple recession in the central incisor, and a Miller third class on the 2.1 incisor with angular incision technique in the donor site, executing a flap with papilla preservation. And this is the result after 8 years. In the next clinical case, another angular incision, in this case, was executed for multiple Miller second grade recession. Tunnel technique I applied. And this is the healing check after 3 years. Still in the angular incision technique, another clinical case, very difficult clinical case, because this 27 years old woman came to my office after having had an implant therapy on 1.1. What was obvious was the poor execution of the surgical technique, causing atrophy of the distal papilla. So, the only solution for this case to augment the volume of the distal papilla is to execute a pedicle connective graft using, in this case, an angular palatal incision. The before and after, we can appreciate the augmentation of the distal papilla with a barely visible scar above 1.2, and that could have been easily taken care of with an desepithelialization, but the patient decided not to undergo another procedure and was very happy with the result. The incision technique for free gingival graft, I'm showing you a short video. Okay. The first linear incision after measuring with a periodontal probe the amount of tissue need. This is the first linear incision. Use the probe to observe, to calculate our tissue, in this case we need. So, at this point, insert the blade to do the 2 vertical incision. This is the other one. And so at this point, I insert the blade horizontally to separate the subepithelial layer from the connective tissue underneath. Okay. And then finally, I execute. Okay, we have to be sure that the separation is absolutely done. And you can use the probe to observe that. And so finally, we have to execute an horizontal incision and remove the graft. And this is now it's absolutely easy without traumatizing the graft. So at the end, will be digitalized will be digitalized. So the difference in the choice of using connective tissue graft versus free gingival graft can be given by the thickness of the palatal masticatory mucosa. But from the latest clinical data published by Zucchelli, it seems that free gingival graft tends to augment in volume over time, as if the epithelial component of the addition favors the production of new epithelial layers in the additional area. So, the use of free gingival graft probably it could be the right solution. But in case of possible bleeding complications, what we have to do? We have to immediately execute a compression of the area with a constant pressure for 5 minutes, applying surgical stitches, obviously, or in the extreme arterial complication, we have to localize the vase, increasing the extension of the flap to tie the vase. Scientific research is giving us a first guideline to have the chance to use substitute soft tissue for increasing the volume of soft tissue. Recently, published research on the Journal Clinical Periodontology 2016 proves that the augmentation of the soft tissue at the implant site results in similar tissue volume increase after 90 days between collagen matrix and the connective tissue graft. But we must underline that this is in only 90 days follow-up. So, an alternative to the connective tissue graft and free gingival graft that I have been using is mucoderm porcine collagen tissue matrix. Recently, we have more studies showing the possibility to use this type of membrane to augment the volume and the quantity of keratinized tissue. For example, work accomplished by the team of Dr. Muccini. Another one is some case reports that Dr. Zafiropoulos documented for covering of gingival recessions. And based off this evaluation, I began to treat patients using mucoderm instead of autogenous graft. For example, this clinical case of a 50-year-old patient came to my attention for his compromised situation under a reconstructive and gingival point of view. Before approaching the reconstructive surgery of soft tissue, my team prepared the patient for a periodontal and restorative approach, and at that point it was able to execute a mucogingival surgery to regain a Miller second class on 2.3, and I used membrane. This is a follow-up after 1 year, and I think it's a very good covering roots. Another clinical case, the second class Miller on the 4.6, lacking keratinized tissue, and also a first Miller class on the 4.3. So I treat with the preparation of the flap with the full split technique, with papilla desepithelialization, application after having prepared the membrane with the length and width desired. At the bottom picture, we can see that temporary crowns was reduced on the new prosthetic merging, and this is the picture of the finished result of the clinical case, where we can notice the augmentation of the keratinized tissue that took place on 4.6, where is it clearly visible the distance with the mucogingival line, and also the resolution of the first grade gingival recession on 4.3. Next clinical case worth reporting. It's a 13-year-old patient came to my attention after having had implant treatment for a man 3 years before. This is a very recent case, so I cannot show the finished result of the healing of the tissue, but very difficult case. But in this case, like this, where a lot of connective tissue was needed to recreate traumatized tissue caused by wrong implant and poor position. For example, on the top left picture, you can see the implant on the 1.3 coming out of the mucosa. But the anatomy of the part made it impossible to get more connective tissue. So, after having executed the regenerative technique with autologous and heterologous bone, I apply mucoderm where we had necessity to recreate the volume of tissue that was previously traumatized. And this is the, after 15 days, the mucosa. Next clinical case, woman came to me for a fracture caused by advanced cavity process on 2.3 main bridge abutment with bone contraction where the dentulia used to be. Immediate insertion after extraction, while on 2.5, where we had an extremely thin bone, I execute a split press technique, filling the remaining bone defects with bone heterologous and reabsorbable membrane. And to augment the volume, I added a mucoderm membrane. And the picture of the new level of mucosa, we can now notice the increase of the soft tissue volume and the anatomy shape changes of the dentular area. Clinical case, 40 years old woman with multiple second-grade recession with severe abrasion. This is another video of the surgery. So I did incision with the flat split technique. This is the phase of the split, and prepare the surgical papilla. So this is the split, and they remove the insertion of the muscles and the mucosa. After that, the full flap. Then you split deeper. So then you start to the desepitalization, first the cleaning of the roots with planing and scaling the roots. It's very important. So So then we treat with gel. Now you can start to control the right thickness of the membrane. And at this point, you use the envelope technique to stabilize and stabilize the membrane, and I start stitching. So we start to stitching to engage the surgical papilla. The first step, you have to engage the clinical papilla. You have to go under the contact point. So you have to go under the contact point without engage the clinical papilla. Then you engage outside the surgical papilla. And now you engage the clinical papilla. And then you have to go under the contact point without engage the clinical papilla, and you have to engage the surgical papilla, and you tie. And you have to do that for all the flap. So and this is the result after 8 months, and I think it's a good result. So this is another clinical case, a very strange case, because it's a 30 years old male patient with a fracture halfway of the root of 2.1. We have to consider that he kept the fracture roots for 8 years with plane to the next tooth. After removing tooth and infection, I execute regenerative technique, and in order to increase the volume of tissue and contrast an eventual contraction of the tissues, I immediately apply a membrane. In this case, the implant was delayed. So, on the top left features, through a checkup CT scan, it's evident a good bone regeneration both vertically and horizontally. And this is 6 months later after the surgery. We also have a good stability and volume of the soft tissue. So this is another short video, kind of sums up all I have been discussing today. This is the chamfered incision technique in this video. But the reason of this video is because it's the same clinical case, is to showing the insertion phase of the implant. We can also see the amount and thickness of the soft tissue obtained with the regeneration with this membrane. So I think that in this clinical case and other clinical cases that I did and I'm doing using this membrane, I think it could be a good solution to use it. So this is the want to show you the thickness. Remember the holding point. And look the thickness now. This is the real time to do this kind of incision. I didn't cut the video because I would like to observe the time to the technique. And look at how was the thickness of the tissue and the quantity of bone regeneration obtained. So in conclusion, we have to have a high prudence in implant treatment with the patient with generalized aggressive periodontal disease. Surgical periodontal therapy before an implant treatment, it's very, very important. And at the end, my experience with mucoderm membrane evaluation is that decrease the surgical times, decrease of surgical and post-surgical bleeding, the possibility to have unlimited tissue quantity, decrease of morbidity, absence of second intention healing areas, and excellent biological answer with high quality and quantity of keratinized tissue. And thank you so much. So, any correlation or periimplant correlation? No, I think that depends of the level of the bone. If they lost the tooth for the periimplantar and the patient, I think it's not different. The problem is the level of the bone. Thank you for the question. I use usually I use the heterologous bone from cow, porcine. It depends. I use usually maxresorb. I use Cerebone, or I use BIOS. It depends. It depends also. It depends of the how is wide the defect. No, it's very. The question is no. I don't suggest to use always this membrane. I'm trying to use this membrane, and in every clinical case, I have a success. This is my experience. I know that there is not a very high level of experience in literature, but I would like to augment this this clinical case, and I think that is a good solution for first of all, when we have problems for the palatal vault, and when there is some difficult situation with some patients. So I think that could be a very good solution. For the fourth question, no, I don't know. For me, the level, I show you the pictures of the level of the thickness of the keratinized tissue. So in my case, I think it's a good solution. It was 5-0, and it was nylon, so polyethylene for the stitches. Next one. Yes, I used scaling group planning. I think that you showed what I did in the short video, and I prepare with PrefGel, for example. No, in this case I'm not sure, but I prefer to cover the mucoderm instead to have the membrane exposed. I think yes, you can use this kind of membrane. Yes. The 9. Okay, and the other one, I don't understand what you ask. Why? Because no, because this is in the video. While in the elevation, periosteal elevation, but in the video I show you in the case of the mucogingival technique, we have to use the full split, and the Zucchelli published a lot of years ago the technique. Any questions? Other questions? So this is a very good question. If I use now the free gingival graft of connective tissue graft, so to cover the roots, now I'm using always free gingival graft. To manage the periimplantitis tissue is depend how is the defect, how deep is the defect. For example, to reconstruction a defect of papilla, it's impossible to use the free gingival graft, but you have to, I suggest, to use the connective tissue graft. Last one, I think. So, I use always, it depends. Probably the question is if I use before to insert the implant or in the same steps of the insertion of the implant. It depends. If I have to do GBR, I put together with the GBR and the mucoderm, and I delay the insertion of the implant. But if I need to put it contextually, I use contextually mucoderm or connective tissue graft or free gingival graft and the implant. This depends on the atrophy and the defect of the bone. I think it's thank you so much, and see you next time. Bye bye.